So postmenopausal bleeding, a red flag not to be missed. Before we go to the postmenopausal bleeding, we have to be very clear, how do we define menopause? Menopause is defined in retrospect. It is after 12 months of the final menstrual period in a woman of menopausal age that we say that the patient is now menopausal. So postmenopausal bleeding is any vaginal bleeding in a postmenopausal woman, that is after 12 months of amenorrhea, which excludes the expected cyclic bleeding in a woman who is on combined MHT. MHT is menopausal hormonal treatment, which was previously known as hormonal replacement therapy. So it's a cardinal symptom of endometrial carcinoma. So irrespective of the amount of bleeding, whether it is a spotting or small amount or a scant or heavy bleeding, all postmenopausal bleeding cases require prompt evaluation for endometrial hyperplasia or carcinoma. About 4 to 11% of postmenopausal women present with postmenopausal bleeding. Coming to the various causes, the postmenopausal bleeding doesn't always means malignancy. There are various causes. About 2/3 they are benign. The important causes are endometrial polyp in 37.7%, atrophy in 30.8%, proliferative or secretory endometrium, which we get on histopathology, 14.5%, endometrial carcinoma in 6.6%, fibroid in 6.2%, hyperplasia without atypia 2%, hyperplasia with atypia 0.2%. The polyps are basically the localized overgrowths of endometrial glands and stroma. They are common in perimenopausal and early postmenopause. They are stimulated by estrogen therapy or tamoxifen, and the malignant potential increases with age. Atrophy, menopause is a stage of hypoestrogenism, which causes endometrial and vaginal atrophy. The collapsed surfaces of endometrium, they cause microerosions and chronic endometritis, which results in light bleeding or spotting. It's the most common benign cause of postmenopausal bleeding. The fibroids, which if even they are present in the reproductive age group, they usually regress postmenopausal. But if they're causing any symptoms like pelvic pressure, pain, or bleeding, or they're enlarging in size after menopause, we have to rule out sarcoma. Endometrial hyperplasia. Endometrial hyperplasia could be without atypia or with atypia. Endometrial hyperplasia with atypia may have coexistent endometrial carcinoma in 40% cases, and it progresses to endometrial carcinoma in 40% if left untreated. So we have to be very cautious about when the report comes as endometrial hyperplasia with atypia. It's seen in perimenopausal age group or early postmenopausal because of the imbalance between the estrogen and the progesterone in this age group. The risk factors are unopposed estrogen, obesity, diabetes, polycystic ovarian syndrome, and nulliparity. Endometrial carcinoma. Endometrial carcinoma is 4th commonest cancer in USA in women. Breast cancer, lung cancer, colorectal cancer, followed by endometrial carcinoma. And it's one of the commonest cancer of the female genital tract in USA. And it's more common post-menopause. It presents with vaginal bleeding in most patients, and it must be ruled out in every post-menopausal bleeding case. Sometimes even upper genital tract malignancies like from fallopian tube or ovarian carcinoma, they may present with a postmenopausal bleeding. 75% of fallopian tube cancers, they also present with postmenopausal bleeding. Sometimes this postmenopausal bleeding may be medication induced. If the patient is on cyclical menopausal hormone treatment, the bleeding is expected. But a patient who is on continuous MHT and the bleeding persists for more than 6 months, even in the form of spotting, it needs to be evaluated. The tamoxifen and phytoestrogens may stimulate endometrium. Tamoxifen is used in patients of breast cancer. Anticoagulants, antiplatelets, they may contribute to uterine bleeding. Other causes could be adjacent organ disease, for example, diverticulitis, perforating into the uterus with uterine fistula. If the patient had received radiotherapy in the pelvic region for any cause, the post-radiation tissue necrosis and end arthritis may cause postmenopausal bleeding, and infections like endometritis or genital tuberculosis. So, what are the risk factors for endometrial carcinoma? The endometrial carcinoma is increasing by about 1.5% every year. It's known as the carcinoma of the urban. And the main reasons are the rising incidence of obesity and diabetes mellitus. And because of obesity, the rising incidence of polycystic ovarian syndrome. The various risk factors are increasing age, unopposed estrogen therapy or tamoxifen, early menarche, late menopause, nulliparity, polycystic ovarian syndrome, obesity, diabetes mellitus, estrogen secreting tumors like granulosa cell tumor of the ovary, and some genetic syndromes like Lynch syndrome and Cowden syndromes. They are associated with very high incidence of endometrial carcinoma. Then if there is any family history of reproductive cancers. So we have to differentiate the bleeding source. The postmenopausal bleeding may originate from uterus, cervix, vagina, or vulva. So we have to evaluate for trauma, atrophy, foreign body, any sexual injury. We have to carefully inspect the lower genital tract. How do we approach to diagnose the patient when a patient presents with a postmenopausal bleeding? The goals are to exclude malignancy, identify non-uterine or intra-abdominal sources. The steps are detailed history taking, very detailed physical examination, general physical examination, as well as the local examination, cervical evaluation, and then finally comes the endometrial evaluation. History taking. First of all, we have to confirm the date of final menstrual period to declare the patient whether patient is actually postmenopausal or she is in a perimenopausal age group. And the previous menstrual history in detail, whether she was having polycystic ovarian disease or syndrome in the reproductive age group, because that increases, or because of chronic anovulation and prolonged hyperestrogenic state, that increases the risk of endometrial hyperplasia and endometrial carcinoma. And secondly, we have to ask before the final menstrual period in a perimenopausal period whether the patient was having irregular cycles or heavy bleeding or prolonged bleeding, because these things the patient usually take as normal, that it is approaching menopause, so this heavy flow and irregular flow is normal. And reproductive history, the parity of the patient is important. This thing, nulliparity, is a high risk for endometrial carcinoma. Any family history of malignancy, especially any genital cancers or breast cancer. Then we come to the present complaints. We have to ask in detail, when did the bleeding start and for how long did it last? What was the pattern of the bleeding and the amount of bleeding? Any precipitating factors like any trauma or any intercourse, associated symptoms, pain, fever, any bowel or bladder symptoms. Then if the patient is on any medication like MHT, tamoxifen or anticoagulants, the risk factors are obesity, diabetes, and family history. Physical examination, we have to do a general physical examination. Calculating the BMI of the patient is very important. Any signs of ecchymosis, any trauma signs. Then we have to do a detailed pelvic examination, locate the bleeding source, assess the uterus and adnexa, and rule out the lower genital tract causes also. We have to evaluate the cervix. All postmenopausal bleeding patients need cervical assessment. If there is any visible lesion, take the biopsy. Otherwise, do a pap smear with HPV testing. Then finally, we come to the endometrial evaluation. The first line non-invasive tool is transvaginal ultrasonography. If the endometrial thickness is up to 4 mm, usually endometrial carcinoma is unlikely, but this is true only for the endometrioid cancers, which comprise about 80% of endometrial cancers. But the 20% of the endometrial cancers like serous cell cancer and clear cell cancer, even the endometrial thickness may be up to maybe less than or up to 4. If the endometrial thickness is more than 4 mm or if it is heterogeneous, the biopsy is required. The advantage of doing a transvaginal ultrasonography is it detects other pathology also, like any polyp or any fibroids or any adnexal pathology. So endometrial evaluation is very important. If the endometrial thickness is more than 5 mm, we have to do a endometrial histopathological examination. The various, if it is a generalized thickness, we can go for an endometrial aspiration or endometrial biopsy. It is office-based, requires minimal anesthesia, gives a histological diagnosis. It's quick and simple, but the disadvantage is the blind sampling may miss focal lesions. So if the ultrasound is reporting a polyp, don't go for a blind endometrial biopsy or blind DNC. Always do a hysteroscopic directed endometrial sampling. And if the endometrial biopsy report comes inadequate and the bleeding is still persistent, again, you have to go for a hysteroscopy. The role of hysteroscopy is it directly visualizes the endometrial cavity and it allows targeted biopsy or excision of lesions and improves the diagnostic accuracy. Further evaluation is if there's a recurrent or the persistent bleeding, we have to go for a hysteroscopy directed endometrial sampling or go for a saline infusion sonography. And if the biopsy was benign initially, but the patient is again bleeding, again we have to reevaluate. And if the report is coming proliferative or secretory endometrium, we have to check for endogenous or exogenous estrogen source. So transvaginal sonography and endometrial sampling for the histopathological examination is the cornerstone of evaluation in any patient with postmenopausal bleeding. If the bleeding is persistent, re-evaluation is mandatory. Thin endometrium does not rule out non-endometrioid cancers. So before I come to the end, I have to just see that what is the role of obesity? Why is the endometrial cancer increasing in developed countries and even in India? The obesity has a great role to play in increasing the risk of endometrial hyperplasia and carcinoma. The pathology goes like during reproductive age group, the increased BMI leads to increased insulin resistant. Hyperinsulinemia results in ovulation, anovulation, and polycystic ovarian disease, which we are finding like an epidemic these days, which is a state of hyperestrogenism without the protective effect of progesterone. So a patient who is persistently anovulatory, she has got a very high risk of getting endometrial hyperplasia and endometrial carcinoma even at early stage. After menopause, how does obesity work? After menopause, obesity leads to hyperestrogenic state by peripheral conversion of androgens to estrogens. The androgens which are secreted by the adrenals and the ovarian stroma, they are converted to estrone by adipose tissue. So the relative risk is so much. The type 1 endometrial cancer, if the BMI is 25 to 30, the risk of endometrial cancer type 1, that is endometrioid, increases by 1.5 times. If the BMI is between 30 to 35, it increases by 2.5. If it is 35 to 39.9, it increases by the relative risk increases to 4.5 times. And if the BMI is more than 40, the risk increases to 7.1. For type 2 endometrial cancer, also there is a increased risk, but not as much as for the type 1. If the BMI is between 25 to 30, the risk increased is 1.2. Less 30 to 35, 1.7, 35 to 39.9, 2.2, and more than 40, it is 3.1. So the key takeaways are postmenopausal bleeding is a red flag for malignancy. Evaluate thoroughly and systematically. Again, I'm stressing that we don't have to ignore even if it is a spotting or a scant bleeding. It needs thorough evaluation. Endometrial thickness less than up to 4 mm, it is usually benign except non-endometrioid cancer. So we have to combine the clinical examination, imaging, and histological findings. Thank you all for your kind attention.
Wonderful, Dr. Promila. Such a short, sweet, and crisp presentation on a very important topic. And I was already telling that you will make it very simple and straight, even for the non-gynecological
I've not
also.
gone into depth of the treatment because that only is for gynecologists because it was on IMA platform. So
Now you can just give a little bit of overview of the treatment.
treatment, we can have a discussion. Anybody?
Yeah. So anybody, if somebody want to ask
Question,
any,
any discussion on endometrial hyperplasia and with
yes.
CPI, atypia, endometrial carcinoma?
Yeah.
Can
Hi,
discuss.
Well, any
Samitra.
other
Hello,
issues you
Dr.
know?
Alka. Good evening.
Yeah,
Issues you-
very, very nice and crisp talk.
Thank you. Thank you
So
so
just
much.
I want to tell you that when there is a ultrasonic finding in the postmenopausal bleeding as polyp, suppose it is like it has come like 16 millimeter. So
Okay.
once you remove the polyp, then how you differentiate between endometrial hyperplasia and simple like
See, if it is
endometrial
a
polyp.
polyp, we have to always.
So doctors are doing the repeated DNA.
If the ultrasound is showing a polyp, we never have to go for a blind biopsy. We have to always do a hysteroscopic polypectomy and the endometrial sampling and the visualization of the cavity and the histopathological
So
examination will determine.
once the polyp is removed, once the polyp is removed, then the endometrial sampling is not very much of not in the quantity as in the histopathology where
No,
are
no.
doing the
If
repeat.
it is,
Is it okay?
if there is some pathology, there will be definitely endometrium. You will get the sample for after the thing during the histoscopy, and the histopathological examination of the polyp and the rest of the endometrium will decide what is the histopathology saying, whether it is a endometrial hyperplasia with atypia, without atypia, or it is
Just
an endometrial
atrophic.
carcinoma. Because the risk of malignancy increases with the age. Even the polyp may show malignancy in a postmenopausal age group.
Because the patients are not getting every year. Like cervical cancer screening is very popular, Dr. Mahavir. But the endometrial screening, endometrial biopsy or ultrasound and screening is not popular at all. So government also should take it. हर साल आपका अल्ट्रासाउंड होना चाहिए, एक साल ET देखना चाहिए.
Endometrial carcinoma, about 90% of patients, they will present with post-menstrual bleeding. 90%. So that is why if it is a
But if
scant
they will have
spotting,
the ultrasound,
even if it is a scant spotting in a postmenopausal woman, you have to evaluate promptly. That may be an indication of this thing. You don't have to ignore whether it is a scant amount. You just
but
ignore
mostly patients are coming
Don't
after
wait for the
7-8
second
years of
episode at all.
postmenopause, no?
Even in the first episode, the patient needs evaluation, prompt evaluation.
Definitely, वो तो होता ही है, but the patients are coming also after the so many years of the
Actually,
menopause
public
and then
awareness is
postmenopausal
required.
wedding.
The main thing
Very,
is
very
the way we are dealing with the epidemic of PCOD, this PCOD, all the PCOD patients and obese patients, they are
Should go
such a
like
high
that.
risk of endometrial cancer later on. It's as it is increasing in USA and developed countries, same is going to happen in India. The cervical cancer will be left behind, endometrial cancer in the urban area especially.
फिर भी cervical screening तो बहुत popular हो रहा है.
Promila, right now there is a lot of stress on HPV vaccination by Government of India, IMA and FOGSI all.
Yeah.
So what is the role of HPV infection, HPV vaccination as far as this endometrial carcinoma?
No, there is no role. HPV virus is only responsible for cervical cancer. Actually, endometrial cancer, 80% is endometrioid, and it is because of hyperestrogenic state. Hyperestrogenic state in the reproductive area age group is in polycystic ovarian patient, PCOD patients, in perimenopausal patient, because there is a chronic, because the ovulation is not regular in the perimenopausal age group, again they are at risk of endometrial hyperplasia, especially the patients, obese patients and diabetes, and in menopausal patients also, because there is no ovulation, no progesterone, But if the patient is obese, there is a peripheral conversion of androgens to the estrogen. So again, it is a state of hyperestrogenism. So obese patients are at a very higher risk. There is no protective effect of it. Is an imbalance between the estrogen and progesterone. Wherever there is a unopposed estrogen, whether it is exogenous or endogenous, it is going to lead to endometrial hyperplasia. There's no role of HPV in causing endometrial cancer.
Does it have any association with the parity also? Nulliparous or
Nulliparity is at a higher risk. Yes.
right? And what are the preventive strategy if we want to tell the society?
That's
See,
what I was telling you.
see, most
Ultrasound
important
every
would
year.
be reducing the obesity. Lifestyle is very, very important, and not giving unopposed estrogens, because there was a study when the unopposed estrogen was given for hormone replacement therapy. So it has never to be given if the uterus is intact. If you are giving MHT, it always has to be with progesterone,
I think,
never only estrogens.
as
And
the 4 millimeter, I think that the 4 millimeter of the endometrial thickness is a very good landmark for detecting the
yes,
endometrial cancer.
more than 4
So
mm, it requires
preventive is to go to
evaluation.
ultrasound. Yeah,
What-
ultrasound
what-
every
See,
year. We should
progesterone has a
all our
protective effect.
relatives.
I would like to ask
That's the thing.
Dr. Mitra and Dr. Manju. I was just thinking कि जैसे जो बहुत obese patients हैं perimenopausal age group में और menopause में, if we use Mirena in these patients, can we reduce the incidence of endometrial hyperplasia and cancer?
Yes.
It gives a
Uh,
protective effect.
Yeah, actually, Pramila, you are very right. I'm sorry I joined a little bit late, but actually, basically, post-menopausal bleeding means menopause is established. But if there is, see, it could be just an atrophic endometritis also,
That
which presents as
etiology,
bleeding.
30% are
Uh-huh.
because of atrophic, only
So,
6.6%.
I mean to say, we have to go into the etiology of the bleeding. And if it is endometrial hyperplasia without atypia, then Mirena is a very good answer, because Mirena will keep the endometrium very thin and it is protective against endometrial cancer. However, having said that, we have to look at the body habitus and the patient's, intelligent follow up. So basically speaking, once we put Mirena and it was no atypia, then we are sure that she'll be fine. Also, if we have done FSH with it, अगर वो endometrial hyperplasia था और proper menopause नहीं था, तो FSH हमें raise नहीं मिलेगा. So we have to, कई बार delayed menopause होता है, perimenopausal होता है. Basically follow up अगर है, तो आप उसको कर सकते हैं.
After the final menstrual period.
on
But
behalf,
I will tell you one thing, Pramila. In our country, people are not so aware. So, अगर obese है और doubtful endometrium है, तो a hysterectomy is very well taken up with the patients, because for leaving the uterus, you have to have proper follow up. So I feel that either आपने Mirena लगा दिया है, because it's going to
I'm
take
just
care
talking
of
of patients who don't have any symptoms. They're just obese. They're at high risk of developing
हाँ,
hyperplasia.
पर आपको उसकी एंडोमेट्रियल सैम्पलिंग करनी है. एंडोमेट्रियम सैम्पलिंग करके
एंडोमेट्रियम
और
तो
फिर
सैम्पलिंग
लगा दो.
होनी है अगर कोई पेशेंट ब्लीडिंग के साथ
हाँ
है, तो होना
हाँ.
ही है.
अदरवाइज ऐसी मिरीना नहीं लगाओगे, क्योंकि
नहीं
अदरवाइज
नहीं, वो
मिरीना
तो
से भी तो
that is
इरेगुलर
obviously
ब्लीडिंग होती है ना.
histopathological diagnosis and
हाँ,
histoscopy के
it
बिना
has
तो
to be
कोई
put
treatment
if
नहीं.
it is needed. You can't just put it.
Even in a post-menopausal women, if patient is showing the histopathology showing endometrial hyperplasia,
हाँ, only then,
even
only
without
then,
atypia, we have
only
to
then.
see whether she is not harboring any estrogen secreting tumor also.
हाँ हाँ हाँ, बिल्कुल.
Is the
But I think
choice.
we have to go into the etiology, and then of course so many times we've done postmenopausal bleeding है, सब कुछ ठीक है, फिर भी the patient opts for a hysterectomy. So sometimes hysterectomy is a prophylactic management for endometrial cancer, you can say.
welcome Dr. Mitra.
Thank you, Dr.
Behalf
MP.
of IMA Haryana, and since all these stalwarts are there, what the message to the young girls would you like to give as far as this postmenopausal bleeding? Of course, it is a very late occurrence, But since, like as you have said, obesity is one of the leading cause. So, what the message would you like to give to the younger generation?
Lifestyle management,
Yeah.
eating, calories, reducing the recent to achieve the normal BMI basically by
Yeah, to keep
uh,
the
Basically,
diet
I
plus
would say
plus
that the
exercise.
women who are having PCOD also have the syndrome X. So GDM, heart disease,
That's
endometrial
a metabolic
cancer.
syndrome plus endometrial cancer. Everything is
So
increased in
the
obesity.
message to the women should be that when they are going in advancing age, their weight should be decreasing. They should take care of their osteoporosis, they should take care of their weight, and they should take care of matlab, their bone health, heart health, everything. Because once estrogens are off, you have the risk of all other, fractures and all. So basically, increasing awareness about postmenopausal bleeding, that it could be a harbinger of malignancy, but it's also a time to review your lifestyle.
thank
One
you.
question from my side. One
Yeah,
question from my side. To ease out the symptoms of menopause, like hot flushing and other palpitation, many of the physicians are using isoflavonoids. So how safe these molecules are?
Isoflavonoids, you need to monitor the endometrial thickness in those patients. They have been known to cause endometrial, stimulate the endometrium.
So should we use them or should we not use them?
Even if you're using, you need to monitor the endometrium. If the endometrial thickness is increased, because you can't combine them with progesterone, because if you have to give, then you have to give a proper estrogen progesterone continuous or this thing. Phytoestrogens alone, if you are using, although the company people say you don't need to monitor, but the studies have shown that phytoestrogens also may cause endometrial hyperplasia and endometrial carcinoma, like tamoxifen.
Okay.
You need to monitor with the transvaginal sonography.
And as we know that whenever the women are approaching towards their menopausal age, there is deficiency of estrogen.
Yeah.
So it may lead to increased cardiac risk. How to
Yes.
mitigate that cardiac risk in such patients?
For
Particularly
the
those patients who are having hyperlipidemia and
lifestyle,
high risk of family history.
because these days MHT is not recommended for cardiac protection or even for osteoporosis protection. Only to relieve the guidelines say only to relieve the menopausal symptoms if they're not being relieved by other drugs. That's
What
only
are
a
the other drugs we
lifestyle.
can use to ease out the menopausal symptoms?
Yeah, menopausal symptom, then they will have additional benefit of cardiac protection as well as bone
No,
protection.
no. What other drugs besides phytoestrogens we can use for easing out the
Uh,
menopausal symptoms?
Besides phytoestrogens, we can use fluoxetine, gabapine, and tea. They give a good result.
Okay. Okay. So, any other question or comment from any other?
Good evening, everyone. Thank you, Dr. Promila, for the wonderful lecture and for touching on all the important points regarding post-menopausal bleeding, and especially spreading the awareness among the physicians regarding the use of these phytoestrogens and all. And it was nice that we could have Dr. Mitra Saxena also joining in. Thank you, ma'am, for joining in and giving your valuable inputs. And thank you to all the participants today. And I hope you all have benefited from this. Thank you.
And the message, which is very loud and clear from Dr. Promila, take care of your obesity because it is mother of many diseases.
Yes.
Yes.
Metabolic syndrome plus endometrial carcinoma.
They go hand in hand.
Yes.
And
Good night,
Pavan,
good
for
night,
your
everybody.
menopausal hot flushes, the only medicine which is very, very effective is low dose estrogens, Premarin or whatever.
Yeah.
But they have to be always monitored if the uterus is intact.
That's where the guidelines are. If they're not relieved, we have to give MHT to those patients if their
Yeah.
life is affected. But if the uterus is intact, it has always to be given combined with progesterone. Never
Low
alone.
dose. Yeah.
If the uterus is not there, you can just give estrogen.
Premarin or ethinyl estradiol.
Thank
Okay,
you.
thank you. Bye
Thank you.
bye.
Thank you, Devi. Thank you. Thank you.
Thank you. Thank you, Dr. Mahavir.